Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. And on these weekly mini episodes, we bring you bite-sized ideas for you to snack on.
Like breathing exercises, book reviews. Maybe we'll review some scientific research, or we'll share some wellness and fertility stories from our listeners.
So if you're looking for a tip or a trick related to your fertility and well-being, then you've come to the right place.
Let's dig in.
Welcome back to The Whole Pineapple. This is our snack edition, and we are thrilled to welcome back Dr. Amy Criniti. Hopefully you listened to her episode last week where we kind of talked about what is an ectopic pregnancy, what are some of the signs, how do we monitor, why is that important, and how do we treat. So now we're going to get into what I think is the next question that anyone that's ever had an ectopic, or even anyone that's been worried about an ectopic, always asks, like, how can I prevent having an ectopic pregnancy? So is this a question that you get? I know I get it all the time. So
Definitely.
Constantly, yeah.
And what do you say to a patient when they're coming in for their follow-up and they just want to know, like, how can I try and have this not happen again?
I always start with, the baseline chance of ectopics, about 1% to 2%. But when there's been an ectopic before, maybe it's more like 10%. So it's still lower than I think people are assuming. They're assuming it's higher than that. But I guess it's individualized. If I don't have tubal imaging for that patient, then I would definitely do an HSG, which is our uterine tubal test. Even if they've had one before, I might still think about repeating it to get a better idea. Now, it depends on, did we do surgery to remove the tube? I might not do it in that scenario, but if we gave medication, I might, just to get a better idea. Maybe we weren't sure about which side, or maybe want a little bit more information about the status of the tube after treatment.
Yeah, I definitely had patients where they had their ectopic managed elsewhere and they come in like, yeah, I think they took out one of my tubes. I don't know which tube it is.
Or the opposite, they tell you it's the right, and then like you do the HSG and it's totally the left.
So if there's any question, I think the HSG can be a super helpful tool, whether we don't know where it was, or we weren't sure it was an ectopic, or maybe a very early intrauterine, or we know it was an ectopic, but we just want to kind of check the status of the tube again. But I always say too, though, even if that tube looks beautiful on HSG, we still know that it may probably not work exactly normally. And then I think it kind of depends on, where someone is in the journey. Like maybe they were already leaning toward IVF, and maybe that would be a better treatment because the risk of ectopic is lowest. Maybe they're not nearly ready for that, and their other tube looks beautiful, and we can tell what side you ovulate from on ultrasound, and we can even sometimes use medication to try to favor, we can't force it, but maybe increase the chance of ovulation from the favored side. So I do kind of go through some of those options, depending on, how patients are feeling about what kind of treatment, what they're ready to think about, maybe what they're not ready for yet.
I'm going to steal that phrase and we can favor but not force, because that's one of the most frustrating things. You'll have someone that's taking medications, their right tube is, has been removed, and they come in and they ovulate on the right for like 3 months in a row. Yeah. And sometimes the medicine, quote unquote, worked. They made 2 eggs and they were both on the right side.
It's the Murphy's Law of blocked fallopian tubes.
Yeah, ovaries and tubes do not communicate about who's open and who's not.
No, unfortunately, it is so frustrating to have somebody that comes in for their 3rd month of trying to get to ovulation on their open side, and it is once again on the blocked side. It's so frustrating.
And even in that scenario, there's still that chance of pregnancy, because that egg can be released from the right ovary and find its way over to that left tube, but that chance is obviously lower. What do you say? Because I have heard different docs in the practice say very different things.
I don't know. We're probably all saying slightly different things.
You are, yeah.
If we're planning something like an insemination, where there's the time and the energy and the cost of doing the treatment, I don't think that they should do it if I know that the side is not normal. Now, sometimes I just don't know, and then it's fine. But if I'm really confident because the HSG is abnormal, there was an ectopic on that side, then I think it's not worth maybe doing that treatment. It could still be reasonable to do timed intercourse because maybe there is, I would say probably less than 5% chance that the other two.
That's what I usually say. I say less than 5%, but
someone told me 3% once. I have no idea if that is actually true or not, but it's stuck in my head. But I usually say less than 5% chance of the contralateral tube picking it up.
Yeah, I definitely have had that happen where somebody had their tube removed. So I knew there was
Yep.
no tube over there and there could be only one entrance into the uterus, and somehow that egg made it over there. So it does happen, but it's unlikely. But, if you want to have timed intercourse just to give that potential shot, then that might be right for you.
But you also bring a good point that the only way to know each month is that ultrasound. Because I've definitely had patients that think that it's like the ovaries taking turns. And again, that's I've complained about this before, I think, but I read Jessica Simpson's biography. And in that, she talks about her quote unquote miracle pregnancy because she had an issue with either tube or anyway, she'd had something where she had a side that was her quote unquote bad side. But she knows that she got pregnant on the month it was on that side. But then when you actually read the story, no, you're just saying that the month before was on the good side. So you're assuming it was the bad side. It's that's not how it works. So
where did that come from? It's such a ubiquitous thought. Where did people with ovaries get told that it's every other month?
It just seems to make logical sense, right? When you walk, you go right, left. You just think since you have two ovaries, they should take turns too.
I just tell patients they're duking it out every month. They're duking it out for dominance. Yes. And it's probably.
Yeah. And it seems like there's always one that's the more commonly more dominant one, but every once in a while, the other one will sneak in there.
So we're going to favor, not force. I like that. I'm totally going to steal that one.
Yeah.
And then you mentioned this in the main episode, but what IVF, obviously reduces that risk of ectopic, but also doesn't completely eliminate it. So I know that's always hard for patients as well. The other thing that we don't talk, I think, enough about in general population is that all these strategies for managing your health and your future fertility also then are good for preventing ectopic risk. So not smoking cigarettes, if you have super painful periods and you're worried about maybe something like endometriosis, getting treatment for that so that it kind of hopefully doesn't progress, avoiding pelvic infections like chlamydia that could potentially scar the tube. So there is a lot that people can do in their early reproductive years to hopefully decrease the chance of ending up having tubal factor in the future, which then increases their risk of having an ectopic pregnancy.
Those are great points. Those are really great points about things that we can't control for everything, but there are some things that we can take charge of that may reduce that chance later on.
Yeah, and smoking's bad in so many ways, but I think a lot of people don't realize how bad it is in terms of your tubes. Yeah. Look at the stats for how much higher the risk of ectopic is with people that are cigarette smokers, and it damages those little cilia that are inside your tubes that are, we're all doing our fingers and moving them like little anemones, but they're in there helping to move the egg along its journey. And if those are not working well, you have a higher chance that an egg is going to get stuck and implant in the wrong place.
That being said, I have a lot of patients where I find blocked fallopian tubes on people and they have none of those things, so it definitely happens. Like you said, you can't control for everything. Sometimes, blocked fallopian tubes happen or damaged fallopian tubes happen for reasons we don't know.
And the other thing that I always tell patients is at least in the future, once you've had that first one, you're not going to be in that same floored scenario that you were the first time where you probably walked into an ultrasound thinking everything looked good. Having had that one and being at risk for another, we're always going to be watching you a lot more closely. So as you said in the main episode, often we're doing additional blood monitoring, an early first ultrasound. We're watching as early as we can to hopefully see that this time is looking normal, is in the uterus, so that we at least, even if we can't completely prevent it, we can hopefully prevent it being such a surprise later diagnosis scenario.
Yeah, I agree. The earlier we know and can treat, just the simpler it is and the less chance of rupture. And so, yeah, that's always going to be our goal, just to follow as closely as we can.
And also, I think they're a little bit easier emotionally because not you're ever prepared,
right.
But if you're being told, gosh, the levels aren't right, let's do it. I feel like that keeps you a little more emotionally guarded instead of just having a home test that looked positive, being happy, assuming everything was great, and then walking into an OB at 9 weeks and being told suddenly you need all this treatment.
Yeah,
so
for sure.
Anything else that you would say to someone who's asking you this very common question?
I think sometimes people assume if they've had an ectopic, there's nothing else that we can do with their tubes. But there is this option of trying to favor the other side, ovulation induction. We're always going to watch closely. I do think that IVF can sometimes be the best treatment if there is more significant tubal disease, and the risk of ectopics never zero with IVF, but it is lower. And sometimes I just think patients feel relief knowing we can like bypass the tube that caused all the challenges and the problems, and we can let both ovaries shine. We don't have to worry about whether it's the right or the left. Like finally they both get a turn. And so I think there's some ways to kind of be positive about that too. There are still rarely ectopics in IVF, but if we know someone's had an ectopic, even in IVF, we kind of take some precautions where we'll transfer the embryo maybe slightly lower. Like we'll do things to really try to minimize the chance of an ectopic even in IVF. So it's part of that history that we're always going to pay attention to and really, tailor the treatment, for the individual patient.
One last thing, talk a little bit about why we can't go in to do surgery to quote unquote fix it too. Like if someone has had an ectopic and the HSG doesn't look normal, like, because I get asked this all the time. Like, people go, why we can do miracles in modern medicine, we can rebuild hearts, right? Why can't we go in there and just like fix my tube?
Fallopian tubes are very delicate things.
They are. I mean, they're very finicky. I think they're a lot smaller than what people appreciate. Like, the tube I'm holding my finger, like you can see it on the podcast, but the actual tube may kind of look like our pinky, but the lumen, the opening on the inside is tiny. Like when we're doing tubal surgery, we have to do with big microscopes, and it's so hard to see. The lumen is tiny. So when a tube is scarred, it's so hard to kind of open that space up again and keep it open. And usually whatever caused the scarring initially, it's just very likely to cause kind of scarring again. Now, some people are just, IVF, I think, is a better treatment for tubal disease than going to repair the tube surgically, but tubal surgery is still an option and something that can be considered. I just think the outcome is usually not as good as it is if we're doing IVF. And tubal surgery is a bigger surgery, sometimes needs to be done open, sometimes requires hospitalization overnight, and sometimes ends up being more invasive, more expensive than an IVF cycle. So pre-IVF, we did a lot of tubal surgery, knowing it wasn't great, but it was the best option we had. And now we just feel like, again, to modern medicine, we kind of have this option that's way better, less risk, way higher outcomes. So we feel like that kind of is what modern medicine is telling us, is that you have this option now that's way better than trying to operate on these tubes.
That brings up one other really good point of people.
I bet it's the same as what I was thinking.
People getting their tubes tied? Yeah,
tubal reversal.
Yep. Exactly.
Yeah.
So
we don't see it much anymore, but it happens occasionally.
And it's kind of the same idea of like, it's really hard to operate on the tubes, and IVF probably is going to be better for most patients. It kind of depends on the kind of tubal. Honestly, if you've had a tubal where we use cautery, like the laparoscopic kind, where we kind of, this sounds terrible, but we kind of cauterize or burn the tube a little bit with the intent that will damage it so things can't get through. Those are like the hardest to repair because you kind of damage the tube and there's not much left to put back together. Clips are a little bit easier. If somebody's had clips, there's not as much damage around the clip placement. So those are times we can bring the tubes back together a little bit better. If somebody's had a tubal after C-section, depending on how much tube was removed, those are also cases where it may be more possible. But then higher risk of ectopic when we've done tubal surgery. So patients who have had tubal reversals are definitely higher risk for ectopic because that amount of tube is still not the same, and that journey of the embryo traveling can sometimes be disrupted when the tube's not totally normal. So that'd be somebody, again, we would know that ectopic might be more likely and kind of do earlier monitoring.
Perfect. And that's another long-term risk reduction for people's futures. I know this is my soapbox too. Like, it's always hard for me when people get vasectomies and tubal ligations, things like, I feel like because we have more reversible options that are really successful for contraception, because still the number one contraception for American women right now is tubal ligation, which always shocks me.
Come on, IUDs. IUDs need to make a push. Reversible.
That actually brings up a really important point, because a lot of times people that they hear about IUDs and they're like, aren't IUDs putting you at higher risk for ectopic? And that's such a misconception, because your overall chance of getting pregnant is very, very low. It's true if you happen to get pregnant with an IUD in place, which is incredibly uncommon.
1% failure rate.
Yes, then they are at higher risk for being ectopic just because you have something in the uterus. But the overall chance of getting pregnant is much, much, much lower. So
true.
Yeah.
All right. Well, thank you so much for sharing all your wisdom with us. See, you didn't need to prepare anything. These are things you know backwards and forward.
All things fallopian tubes.
All things fallopian tubes. I love it. Well, thank you both so much. It was really fun. I love this podcast. I've listened to it and just think it's awesome. So I'm really honored to get to be part of it. Thank you.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.